just thrilled to have everyone. We know everyone is very busy. It's a difficult time we live in, and we hope to be able to provide you with helpful information and to assist you wherever you are on your journey towards family building. So there are, in my quick 10 minutes that I'll be speaking, I'd like to give you 3 main points. Number 1, if you think you have a problem, then please seek help. Number 2, age is the most important prognostic factor for pregnancy prognosis. And number 3, I will go through the testing and the potential options for treatment that we usually discuss with our patients. So let's start with, is there a problem? Well, these are the definitions for infertility according to the American Society for Reproductive Medicine. If the patient is under 35 years old, then 1 year of unprotected intercourse with no pregnancy, and if over 35, then 6 months. And you'll see as we talk about age in a few moments, why, again, this is so important. So in my next slide, I want to show you, I get a lot of questions about how long does it take to get pregnant? You know, I've been trying for this many months and that many months. And this is important, of course, relating to the first slide about the definitions of infertility. So if we take a couple in their mid to late 20s, which most people feel is peak fertility, after they try to get pregnant for 1 month, 25% of them will get pregnant. So it seems kind of low, 25% only, but that's after 1 month of trying. But see what happens after 6 months of trying, and more importantly, after 1 year. We do expect 85% of patients to get pregnant. So it's that other 15% then comes to the doctor for evaluation. Now, what happens if you try another year? So you try for 2 years to get pregnant, then that number goes up to 93%. And you can see that waiting an extra year beyond that only captures a few more percentage. So after 1 year of under 35, we expect 85% of patients to get pregnant. Next slide, please. So this is a slide that I think is well known to most people. So this is the pregnancy rate after 6 months of trying. And the main point is fertility decreases with age. So if we look at a 25-year-old, after 6 months, she's got a 60% of getting pregnant. After 12 months, closer to 85, maybe even a little bit higher. At 40, pregnancy rate will go down to 10% and even lower after the age of 40. So fertility decreases with age. So next slide, please. Not only does fertility decrease with age, but miscarriages increase with increasing age. And again, it's all about the age, which reflects the egg. So it's all about the egg. So as the patient gets older, the eggs decrease in both quantity and quality. And it is thought that the best eggs go first. So then miscarriage decreases with age. As you can see, sharply increases after the age of 35 to 40 and definitely over 45. Next slide, please. Not only does miscarriage increase with age, but so does the risk of having a baby with a chromosomal abnormality. Again, it goes back to the maternal age, the egg, the quality, the quantity. So at age 30, at birth, that patient would have roughly a 1 in, let's round and say 1 in 400 chance of having a baby with a chromosomal abnormality. But at age 40, it will be 1 in 65. So there is a very sharp increase in chromosomal abnormalities at birth. So chromosomal abnormalities are the 46 chromosomes that we all have. So how they're arranged 1 through 23, but there's 2 copies of each. So these chromosomal abnormalities, of which Down syndrome is one you may have heard of. The other name for it is trisomy 21. So that means that chromosome number 21, there's 3 copies, not 2, and could be a problem. So chromosomal abnormalities increases with age. So if we look at the next slide, which is the causes of infertility, you can see that the single biggest group is actually male factor. So this is followed by tubal disease or pelvic. So diseases such as endometriosis, tubal factor, pelvic inflammatory disease, followed by ovulation. There is a 10% chance of unexplained infertility, and then rare or unusual causes is less than 5%. Next slide, please. So the initial evaluation for a patient who has a problem includes hormone evaluation, which is usually done between day 2 and day 4, with day 1 being the first day of flow, an transvaginal ultrasound that will take a look at the antral follicle count as well as get an overall picture of the pelvis, hysterosalpingogram or sonohystogram, which looks at the uterus and the fallopian tubes. Could you go back to that slide again, please? Then a progesterone level could, about 6 to 7 days later after the ovulation, could confirm ovulation. A semen analysis, a general obstetric prenatal package. So we do want to make sure that we know the blood type. Are they immune to German measles? What about is the patient anemic? This blood work to make sure the patient is healthy before she goes into pregnancy. And then genetic carrier screening to make sure the patient and her partner are not both carriers of the same disease that could be transmitted to their baby through an autosomal recessive fashion. Next slide, please. So this is an example of a normal hysterosalpingogram. So it is a dye test done in radiology with fluoroscopy. So the white is the dye. You can see the very middle picture is the uterus, completely normal. You can see the fallopian tubes. Those things that look like bubbles are actually the fluid going out of the fallopian tubes, demonstrating that the tubes are open. Next slide, please. This slide is something that we do right in the office, a saline ultrasound. So you can see we put in a catheter, but this time it's done under saline with 3D ultrasound. We can find things such as a polyp, which is in the top right corner of the picture. We can see a normal uterine cavity. We can also see the fallopian tubes as the fluid goes into them. Next slide, please. So the semen analysis, there are several parameters to look at. The count, which should be over 15 million per ml, the motility, which should be over 40%. The morphology or the shape is thought to be important with fertilization, and in our laboratory, we do have a limit of 14% or higher, and then white blood cells could be an indication of infection. So because of the high amount of male factor, we always order a semen analysis on the male partner. Next slide, please. So additional testing, depending upon the situation, the patient might need additional hormone testing, and then endometrial biopsy is a little catheter that goes in the uterus to take out some of the uterine tissue for analysis with the pathologist. Laparoscopy and hysteroscopy are both surgeries to be done to look at the pelvis and look at the uterus. Next slide, please. So depending upon the etiology or the cause of fertility, most fertility treatments fall into 2 major groups, either ovulation induction with intrauterine insemination or in vitro fertilization. Ovulation induction means to induce ovulation for those patients who are not ovulating either consistently or perhaps not at all. Next slide, please. So for oral medications, there are 2 out that are available. One is clomiphene citrate, which has been around for a long time. The other one is letrozole, which is actually a drug used for the treatment of breast cancer. But both of these medications are effective in promoting or inducing ovulation in the patient who needs it. Next slide, please. Now, there are stronger fertility drugs in the form of injections, and usually the injections are subcutaneous. They're very small. There are FSH, FSH plus LH, all these different ones, HCG trigger, progesterone in oil is a supplement. So these are some of the other medications that can be given that are non-oral forms of fertility medications. Next slide, please. So an intrauterine insemination is where the husband gives sperm, and our lab will prep the sperm to separate those that are moving from those that are not moving. So we'll only take only the motile sperm, put it in a little catheter, and put it into the uterus as illustrated in this slide. It is done easily in the office, takes about 10 minutes. and it puts the sperm into the uterus where it can go into the fallopian tubes and meet the egg as the egg is coming down at the time of ovulation. Next slide, please. So in contrast, in vitro fertilization is where the patient will usually take injections to produce multiple follicles and therefore multiple eggs. Then the eggs will be retrieved, as you can see on the left-hand side of the picture. It's done transvaginally with the patient asleep. A needle is attached to go into the ovaries to take out the eggs. The husband gives the sperm and the eggs are put together in the test tube, and then about 5 days later, the embryo is transferred back into the uterus. Similar to the insemination procedure, but it is a catheter that goes into the uterus with an embryo. So this is in vitro fertilization. Next slide, please. So I want to show you our pregnancy rates for IVF from last year and tell you and give credit to the IVF laboratory. You'll be speaking to our IVF laboratory supervisors. You'll be hearing from them in a few minutes. And I do think that the success of IVF is largely dependent upon the expertise of the laboratory. So it's very important to know the capabilities of the lab and what the lab can and cannot do. So our pregnancy rates last year very mimics the normal pregnancy rates in patients. So again, pregnancy rates decline with age, even with in vitro fertilization. But we can get pregnancy rates of about 65 to 69% in someone that's less than 35 years old, and will decrease to approximately 20% if they are over the age of 42. So again, pregnancy rates have are strongly impacted by age. Next slide. I believe that ends. So if you want to have a quick look at your fertility, we do offer something called fertility awareness checkup. The patient will call the call center. We make an appointment. We check 4 different things: day 3 FSH and estradiol, which are blood tests; follicle count, antral follicle count, which is done by ultrasound; and then a semen analysis. And it is $90, and we credit you the $90 if you make an appointment with one of the doctors, and the results are called within a week by one of the nurses. So it's a lot of patients like it. It's very popular. It's just to get a few tests done to get a quick assessment of fertility. So I believe that ends my slides, and I am available later for questions. So really happy to have everyone here today and joining us this afternoon.
Thank you, Dr. Euler. We are going to move on to Peter Harvey. Very excited to have him here today. You have so much expertise. I'm just going to let you go ahead.
Okay. All right, Maren, thank you very much. And thank you, Dr. Euler, for your intro. And I want to welcome everybody, and I want to thank everybody for joining in. My name is Peter Harvey. I am a licensed acupuncturist and also an herbalist, and I'm also board certified in reproductive medicine in my field. So I am the owner of Eastern Healing. We're located in Wheaton and in Joliet area. I have over 23 years of clinical experience, and my clinic specializes in fertility, women's health, and all type of pain disorders. Next slide, please. So why do I partner with FCI? Well, this all started quite a few years ago. I needed a reproductive clinic to refer to. I got pretty busy, and I met Dr. Euler a few years earlier. She actually did a couple operations on my wife, and I knew she was going into reproductive medicine, and her clinic happened to be close to mine, so I started sending her patients, and I found her to be very receptive to what I did and very patient-centered. And then she was really interested in what I did, so she started sending me people, and we started collaborating together. Next, please. So what are some of the options when a patient comes in to seek treatment? Well, of course, acupuncture, that's the obvious one. Acupuncture with electrical stim, you could see the little electrodes hooked up to a patient there on the table. That's used a lot to increase a lot of blood flow to the uterus and to the ovaries. Moxibustion, that's when we're burning, herbs over specific points. We use it for I use it a lot to turn breech babies in practice, but also to warm a uterus, women who have a lot of painful menses. Cupping, which everyone's seen from the Olympics, Chinese herbs we use, dietary lifestyle counseling, and then we also do a little bit of Chinese massage, known as Tuina massage. So what are some of the benefits and use of acupuncture? Well, there's a lot of research out there, and the current stats where they lumped together all of the research studies and took a look at them, it's very difficult to say, hey, is this good? Isn't this good? And a lot of the studies were poorly done. They were either done where there weren't enough people in the study, or they only treated them twice and then that was it. But there are a few of them out there that I really like. This one about electroacupuncture increases ovarian blood flow. This is one of the big reasons why reproductive clinics send patients to us, is to help with the ovarian blood flow, especially in patients over 35, and also to help with uterine lining. A really good study was done. It's actually a retrospective analysis done about whole system traditional Chinese medicine, acupuncture, herbs, and diet. It was associated with live births, more live births than acupuncture alone, and more live births compared to just IVF alone. So when it all teams up together, that's when we see our biggest impact. We've also found that it increases serum cortisol and prolactin and improved IVF outcomes. I know it sounds contradictory to increase cortisol and prolactin, but basically what this study shows is it brings it up to more normal levels. Next slide, please. One of the biggest reasons why reproductive clinics do send patients to us is they found that it does decrease the stress of the patient going through this. I found in my own empirical analysis and working with patients over the years, I find it gives the patients a large sense of empowerment and hope, and we give a lot of support to patients. Patients want to be involved in their care, and so we give them a lot of homework and work to do on their own as well. It also minimizes side effects of medications, and then again, we work with uterine lining issues, migraines, ovarian hyperstim, and everything else. Next, please. So when can acupuncture be used? Well, pretty much at any stage of the patient care. In a perfect world, we would love to see a patient 3 months prior to an IVF cycle because it gives us a chance to really work with them. If not, that's okay. We work around all that. We will not interfere with any kind of Western medical treatments. We're only going to enhance it. And again, for prepping for IVF and also IUI cycles. Next. So when are traditional Chinese herbs included in treatment? Well, this gets a little bit trickier, but basically we include them throughout the entire cycle, and it really depends on what we're trying to accomplish. We design formulas very specific for the patient.
There we go.
Okay.
You are the host.
Thank you so much. I'm so sorry about that. Tiffany and Peter. Judy, we're back. Okay. So next we have our lovely embryologists, and I'll have them introduce themselves.
Hey everybody, we're happy we got the slides back because we have some fun video pictures for everybody. So thank you for joining us today. This is Becky. She's been an embryologist for 19 years. I'm Mariana. I've been doing IVF for 8 years now. We're very proud of the work we do, and we're very excited to be here with you today to share what goes on behind the lab doors. IVF started in the late 70s. The first IVF baby was born in 1978. Our lab director, Jürgen, who couldn't be here with us today, has been in the field from the very beginning, and he has contributed to lots of the research that have been done. We've had millions of healthy babies born since. Next slide, please.
Yeah, like Mariana said, IVF has come a long way. Thanks to advancements in research and technology, success rates have now increased to over 70%, whereas back in 1980, they were only around 25%. Next slide.
So what we do in the in vitro fertilization lab is basically mimic the environment of a woman's body. The media we use in the incubator conditions allow the cells to grow as if they would in vivo. So in the lab, we keep very strict conditions, and that's why we believe we're able to grow very healthy embryos and maintain some of the highest pregnancy rates in the country. Next slide, please.
On any given day in the IVF lab, there are a multitude of procedures that needs to be done. Some of the tasks we do on a daily basis are sperm preparation, oocyte retrieval, ICSI, which is injecting sperm into the oocyte, and then we check for fertilization the following day, embryo culture from day 1 all the way through day 7, embryo transfer, cryopreservation or freezing of oocytes and embryos, and embryo biopsy for pre-implantation genetic testing, or PGT. All of our embryologists in the lab are cross-trained to do all of these procedures. Next slide, please.
So like Becky mentioned, one of the procedures we do is sperm preparation. So in this video, we are actually selecting a sperm to inject inside of an egg. So just a moment ago, we pushed away a sperm that was somewhat abnormally looking, and we're choosing this normal looking, beautiful sperm that was swimming very nicely that we're gonna pull into our ICSI pipette and use to inject inside of an egg. So basically when we're preparing a sperm sample, we are processing it so that we're selecting for the normal and healthy sperm to use when fertilizing an egg. And then that sperm will stay in the pipette until we will go ahead and inject it inside of an egg.
Here we're showing the egg retrieval. This is done under anesthesia where the physician aspirates follicular fluid from the ovaries using ultrasound guidance. Then the lab is given the fluid to search for the eggs under a microscope. Next slide, please. This is what the oocyte initially looks like after the retrieval. You can see all of the cells surrounding the egg. Those are called cumulus cells. Next slide. And then about an hour after the retrieval, the cumulus cells are removed so we can check for maturity. A mature egg will have a polar body, which you can see on the right-hand side of this egg in the picture. These are the mature eggs that will inject with sperm. Next slide.
So here, this is the process of ICSI, intracytoplasmic sperm injection, where we are injecting one sperm per egg. The alternative to this procedure is conventional insemination, in which we would keep all of those cells on the egg and not remove them, and seed the sperm around the egg and let it naturally penetrate the egg and fertilize it on its own. Typically in the lab, we do mostly ICSI. This allows us to get a good look at the eggs and be able to diagnose any problems that are going on with the egg quality. And here you can see us depositing a sperm right in the center of the egg after breaking its membrane and gently removing the needle. That is ICSI right there.
All right, and then after around 18 hours after doing the ICSI, we'll check for fertilization. We're looking to see both maternal and paternal DNA present, which we can see by the 2 pronuclei here in this picture. Next slide. Then on day 2, the embryo has divided to between 2 to 4 cells. We don't check embryo development on day 2. We try to minimize opening the incubator and disturbing culture. So we leave them in there that day. Next slide. On day 3, which you see here, we do check development. The embryo should be around 8 to 10 cells at this stage. Next slide. And then on day 4, this is what we should start to see. The cells start to compact and form a morula. Next slide. And then finally, this is the blastocyst stage, which is what we like to see on day 5, 6, or 7 of development. At this stage, we can transfer the embryo, freeze it, or biopsy it. It's also important to note that any fertilized embryo, only about 40% will make it to the blastocyst stage. Next slide.
So like Becky mentioned, at the blastocyst stage, a patient may elect to do an embryo transfer. So this can be done on fresh embryos on day 5, or we can do a transfer with a frozen embryo, in which case we thaw the embryo the morning of the transfer. So to do an embryo transfer, the patient is typically awake. The physician places an outer catheter up through the cervix and into the uterus. In the lab, we will load up the embryo in an inner catheter in a little bit of media. We'll go insert this catheter into the outer one that the physician had placed, and the physician will then plunge the embryo into the uterus, where the embryo will hopefully implant and continue to grow. Next slide, Leah. Thank you.
All right, and this video shows how we do an embryo biopsy. So the purpose of a biopsy is to check that the embryo is genetically normal and healthy before implantation. So we'll make a small hole in the zona using a laser. And you'll see that here in the video. And then we'll insert the biopsy pipette through the opening and pull a small portion of the outer cells out of the opening. And then that portion will be removed also using the laser. So that's about 5 cells that we're trying to remove. All right, so that is separated. Then the blastocyst that's left will get frozen and it remains in the IVF lab. That other small portion will place into little tubes, and then those get sent off to the genetic company, who will then let us know if the embryo is normal or not. And then those embryos can be used for transfer in the future. Next slide.
So, one back, yeah, thanks. So cryopreservation, otherwise known as freezing, is a key component to a successful IVF program. FCI was actually one of the first programs in the world to adopt vitrification, which is now the accepted protocol on freezing. Vitrification is a flash freezing process in a glass lake stage, and this avoids any ice crystals from forming, which could damage the cells. This differs from the slow freezing process, which was used years ago and could potentially damage the cells. In our lab, we freeze eggs, sperm, and embryos every day and are confident that we have perfected the protocol. Once we freeze any type of cells, they remain in that stage undisturbed until the patient wishes to proceed with treatment. And if that means 10 to 20 years down the line, they'll be safe with us. So, next slide, please. So this is our team, part of our team at least, and we really believe that having a great team is crucial when running a high-functioning IVF lab, like Dr. Euler had touched on. I can truly say we all love what we do. We genuinely have a lot of fun, and we really enjoy sharing our knowledge and encourage you all to reach out if you have any questions. This will keep you very engaged in your treatment. So thanks for joining us, guys.
Okay, thank you guys. I'm trying to get Peter's up here. Peter, were you able to kind of speak a little bit more after the PowerPoint, after my computer went on the fritz?
A bit more.
Okay.
I I don't think there was a lot left of my presentation, maybe 2 or 3 slides, but I'll know the minute, if you're able to get it up, so.
Yes, give me 1 second. Oh, I'm really glad I have 2 computers.
Again, like we've talked, I still have problems turning on my cell phone, so,
I just cannot believe this happened. Okay. Here we go. Okay, so you were about here.
I believe I'm beyond that.
Mhm.
That's right. So getting back real quick, I think I touched on this. We do refer to Fertility Center of Illinois for a lot of advanced care and diagnosis. And again, like I said, we like the Western diagnosis because I converted to an Eastern diagnosis, and this is how I know how to treat. We create treatment plans according to what the patient schedule is with a reproductive clinic. So patients come to us from FCI, and we see them in every stage of their process. And so we design and work around whatever, if they want IUIs, if they're about ready to start IVF, if they have time to work with us, great. We will design anything, anything that they want or need. We do a lot of prep, for IUI and IVF cycles, and we do work in conjunction with FCI on that. I know Dr. Euler and I have talked many, many times over patients' schedules and what she's hoping to achieve and how I could kind of jump into the process. I do, as I said, consult with your doctor and nursing staff. That's very common, and I'm even using patients know to talk to the ultrasound person saying, oh, how many eggs does an ovary, which side is responding better than another, how's the lining looking? And again, we also treat a lot of patients who may not, at the present time want to try IUI or IVF, but we still send them there for monitoring, and that's why I like working so much with FCI, is they're really flexible. I think I've worked with them for 16 years, and even just for monitoring and what I'm trying to do. And then if things still aren't working out, well, then you have a clinic, that you're already familiar with, you could jump right into and work with. Next slide. Again, we do work as a team to increase your chances. I've always been impressed that FCI wanted to round out their patient care, with also a holistic approach and be able to offer this to patients as well. Again, it really goes back to what I was saying. I really believe that they're very patient-centered. I know every doctor at this facility, and I've worked with many of the nurses and even the people behind the scenes, and it's always about the patient, what's best for the patient. And again, thank you, for your time. This is some of my information. Eastern Healing, we have 2 clinics currently in Wheaton and Joliet. And again, thank you for taking some time to come out and listen.
Thank you, Peter. Okay.
Thank you.
We are going to turn this over to some questions so our experts can answer. So if anyone wants to utilize the chat, make sure.
I think I'm up next.
Oh, I'm so sorry, Allison. Oh my gosh. It's
That's all right.
Okay, go ahead.
I talk really fast, so this
You want the floor.
you can definitely be sending in your questions because it's a good time to start thinking about them as well. But yeah, my name is Allie. I'm one of our clinical nurses here at FCI. I've been with FCI for 3 years. I actually started as a home office nurse working with Dr. Euler, actually, right up front, and then have transitioned in the last year to research. So I'm very familiar with lots of aspects of the clinic. And as kind of everyone's touched on, we all work together. So we kind of all know what's going on. But each physician has their own team of nurses. So a lot of people, as you go through your treatment, you'll see that different names of your nurses contacting you. And it's because we all work together. That way we have seamless coverage and we all work with your physician to know, to be in the know of what's going on. We're your main contact for the cycle. So you've heard from lots of different people today, and the center of all that is your treatment plan, and you're at the center working closely with your nurse to ensure that all those pieces are coming together for your cycle. If we help answer questions as far as what's next and what do we still need before we can either proceed or go to the next step. And if there's a question that we don't know, then we go to the next, the expert who does know. And that might be your physician. That might be the andrology lab. It might be our embryologist. We will always get you connected with the next person that can help if that's not us that knows the answer. Depending on your type of treatment, we coordinate with the IVF Surgery Center, the phlebotomy lab, ultrasonography, our financial coordinators like Judy, our insurance verifiers, and even the schedulers, just to make sure you're able to get in and get on the schedule when needed. So we coordinate your care. That's our number one role that we work for. The second thing that we do, and these I say number one, but not most important, just there's four areas. We also advocate for you. So your treatment goals are our priority. We want to make sure that feel like you're being heard and making sure all the teams are communicating well with you to make sure you're getting the best care possible. We want to help you succeed. We make your plan to carry out what you and the physician have decided. So when you meet with your doctor, they make a plan for you on how your treatment's going to go forward. And then we're vital in helping to ensure that that plan goes smoothly. We also understand that this is a super overwhelming process. Some of us at FCI have been through fertility treatments ourselves. Others have not, but have been in this journey with our patients to understand that it's very overwhelming. You're getting hit with new lingo, with new acronyms that nobody knows, and it just can be so overwhelming. So we are there to walk you through it and also help you coordinate when needed. So we advocate for you when you might need to go to see our psychologists and get that extra help dealing with the emotional side of things. Or we partner with groups like Peter at Eastern Healing to help get the holistic side and get everything in line to reach the main goal. And that's not always pregnancy. Your main goal might be freezing the most amount of eggs for you to use later. It might also be building your family. Everybody has their own different goal. And so as the nursing staff, that is our role, is to help you fulfill and reach your goal. We also are the educators for, again, the step of your cycle, using your medications, knowing where you're going to be and what you're doing. And we use online resources with that, as well as Zoom in our world right now. And so some of the online resources you might not be aware of is that some of our physicians have Instagrams and are incredibly just out there getting information out there, so you can find out more about what's going on with certain either hot topics or just different fertility items. We have educational videos and articles on FCI websites. We have a newsletter that goes out where our physicians share information about different fertility diagnoses, as well as testimonials and different information on our Facebook page. We are huge fans of utilizing videos for medication administration and then walking you through that as well to help you be as successful as possible. My one rule, though, is no Google. Google is not your friend. It's just like, Yelp. If you go and look on reviews, everyone who has a bad experience is going to go shout that to the from the rooftops, but you miss those 100 other people and only hear the one, and you miss those 100 other success stories, which is why I point out like our FCI testimonials and Facebook page, so you can see people who have gone through it and been successful as well, and not be drowned out by either Dr. Google, who will tell you that you have 10 million things wrong with you when you don't. But as nursing staff, we will also tell you over and over again, don't Google, because you're going to hear the worst things. If you have a question, come see the professionals, come see your nursing staff, your doctors, who can give you a straight up answer that's based on research and fact and not your neighbor's experience. And then the last thing we love to do is celebrate with you. We love sharing in your successes. We laugh with you when you're laughing. We used to hug pre-COVID-19. Now we just kind of air five and air hug as much and as best as we can. But we're with you in that. The amount of times I've cried at work was not what I expected when I went into my career. And just comforted, you know, during the hard times, and honestly cried at both happy and sad times. It gets me both going either way. And we want to be there whatever way you process. If that's wanting to talk with Dr. Edwards, if that's wanting to take some time by yourself, if that's wanting to process at home or with us in the office, we are here to just be, you know, for you what we can to support you on your journey. I want to wrap up with some tips for treatment. The first one is to please be kind to yourself. This process is tough. It is a great time to relax and take care of yourself, do some extra pampering. This is not the time to start a new diet that is, you know, going to make you very stressed and challenged. It's not the time to deep clean your house and start a new huge overhaul or to start a new job. We understand that these things do happen, but if they can be avoided, we definitely want to give you your best, you know, relaxed self going into this, knowing that adding in that fertility journey adds in enough stress in and of itself. It's the perfect time to pamper yourself, eat some of your favorite foods, take some nice naps, and just relax and know that this is a time in your life that will pass. It does not last forever. But it is a very, can be a very stressful or just even intense time where you're learning new things. We also, as the nursing staff, will always stress to limit travel. And just as right now with COVID-19, there's obviously a lot of limited travel anyways, but there's been travel restrictions where we've had issues with people being able to get back to their monitoring center or having a monitoring center close, and, you know, if they're out of state. And so we just always recommend staying home for those, you know, that intensive time of your treatment. If you're in an IVF cycle, the whole process is not, you know, super intense. It's like about a 2-week time frame where you've got a lot of monitoring and you're coming to see us a lot. And then in other cycles like an IUI, you're coming in for certain monitoring appointments, but we just recommend limiting that travel, limiting your scheduled obligations so that you can just focus on you and your partner and just your goals during that time. So just as the nursing team, know that we are here to help. Your goals are our goals, and we just want to help you succeed. Thank you, guys.
Thank you, Allison. Okay, now we'll go over to the question and answer. So I did receive a few questions in the chat, and I'm just they'll stay completely anonymous, and I'll just read what it says. And then based on the content of the question, our panel can answer, multiple can answer, you know, there's always more than one answer for all of these questions, especially with fertility. So this one says, if you're going through the process as a single woman, what is the timeline of treatment? I'm basically looking for a month-to-month understanding of what's involved and how long the process takes. So single woman. You can
So
go ahead.
do you want me to answer, or Allie? I think I would say that it depends on what the patient, what she wants to do. So a single female that is freezing her eggs would be different than a single female who is using, let's say, anonymous donor sperm for intrauterine insemination, where I think the process begins in a similar manner, which usually begins with testing and evaluation. We want to have up-to-the-date information on your hormonal levels, your ultrasound, your uterus, your fallopian tubes, etc. So that usually only takes 1 month to do. And following that month, then we can go in the next month to either egg freezing or treatment with a donor sperm, if that's what you mean. So if you want to pursue donor sperm, we will have you see Dr. Edwards, because we do highly recommend all women seeking what we call third-party reproduction, donor egg, donor sperm, or gestational surrogacy to see our clinical psychologist. And then we will refer you to the information that you need from the sperm banks to obtain the donor sperm, and that should start relatively soon. The donor sperm can be overnighted to our practice, so there is no problem with receiving it if that's the treatment that you want. So I would say 1 month of testing, and then either the next month into treatment, or maybe even 1 more month, but it should be very prompt.
Anyone have anything to add? I think, you know, that was pretty succinct, because this question did not specify whether it was egg freezing or building a family. This next question is, if we find out that we have an abundance of eggs, and when going through the IVF process, many eggs were able to be fertilized, which is a great thing, why would we not be getting pregnant on our own prior to IVF, knowing that I already create an abundance of eggs?
Well, I think that depends upon why there's an abundance of eggs. I think an entity that comes to mind is something called polycystic ovarian syndrome, where there is an overabundance of eggs. The follicles, we use ultrasound to count the follicles, so that could be a potential contributing factor to fertility. So making a lot of eggs with IVF does not necessarily mean that you should automatically be able to get pregnant on your own. It depends on whether you're ovulating on your own, what your cycles are like, etc. So I think I'd need to know a little bit more, but just from listening to the question, it could be that this person might have polycystic ovarian syndrome, which actually might be difficult to get pregnant on your own if you are not ovulating and releasing an egg consistently every month.
Could it also be a male factor?
Could be, because it's not just, the eggs. We do have to have sperm. We also have to have the eggs and the sperm have to meet in the fallopian tube. So it could be a tubal factor. It could be, a uterine factor. We will have to make sure. That's why we usually do that 1 month of testing first to try and get a really good idea of what so 40% of patients have more than one problem for fertility. So that is why we have to look at everything first. It usually only takes 1 month to do the testing, and then we can advise the best type of treatment.
Great. Okay, we have one for Peter. Do you see IBS as a common hurdle in infertility? If yes, how?
No. I look at IBS a little bit differently. And so, in our medicine, what we want to do is get the patient as healthy as possible for IVF or IUI or trying on your own. And so with that said, a lot of our patients come in and they've got IBS, or I've treated patients with Crohn's who have conceived as well. It's more about teaching you how to manage it, how to treat it, how to work with it, on your own. There's a lot of effective ways of treating it in Chinese medicine, and not just with acupuncture, but herbs and dietary therapy and even mind-body therapies too.
Great. Why is Propecia finasteride, I hope I didn't butcher that, bad for my husband to take while we are trying to get pregnant? So I'm guessing this is a medication.
Yes, it is. And, I don't think that it necessarily means that if you take Propecia, the man is going to have an abnormal semen analysis. I've seen both ways. So I think it depends on the dosing that's used, how long it's used, but I've seen men have normal semen analysis using Propecia, and I've seen them not. So I think obviously if it's going to affect the sperm count, then they should stop. But I also think that is a place for our practice. We work very closely with a male infertility specialist. In fact, I'm in the Hinsdale office today, and we have Dr. Olander, who comes to the Hinsdale office on Tuesday afternoons to do consultations with our patients. So that is where I would engage his expertise and consult with him and see. But as far as my own patient experience, I don't think it necessarily means that they can't be on it. It depends on how it affects, if it affects the semen analysis of the particular person.
Okay. Are full services being offered right now? Again, everyone can answer. Yes.
Yes, it is.
Mm-hmm. If IVF does not work, what would next steps be? And what could be making such viable eggs not successful if there are no other noticeable problems? So we can kind of, the previous question that Dr. Euler answered. If anyone. If IVF doesn't work.
I think I'd have to know why IVF is not working. Is it an an egg? It seems like there's a lot of eggs. Is it an egg problem? Is it an embryo problem? Have the embryos been tested for genetic testing? Has the uterus been tested to make sure that there are no polyps or fibroids, any kind of infection in the uterus? I'd have to know a little bit more to know why IVF wasn't working. So I think that requires further testing. That's one of my slides that said additional testing. This would be an indication for additional testing. Perhaps a hysteroscopy needs to be done to look directly into the uterus to see if there's any abnormalities in the uterine cavity. Perhaps further testing needs to be done, you know, at the level of the timing of the, or maybe the stimulation protocol. We'd have to look further, and this would be a time for further testing.
Mm-hmm. How does sleep impact effectiveness of treatment? I have a job where I occasionally need to work late, sometimes 3 a.m. in the morning, and I'm unsure if I should tell my job that I cannot support that anymore during treatment.
I can jump in. I think that, you know, we have a lot of patients who work different shifts. We have nurses who work the night shift. We have other people who do different types of jobs. So I think rest is very important. Sleep is very important, and it cannot be underestimated. So I think if you just have to do your best to get your rest, and I don't think it necessarily has to be from, you know, 11 p.m. until 6 a.m. or what, let's say most times people sleep at night, but we have a lot of people, like I said, that work different shifts, and we all have our jobs and we have to do what we have to do, but we cannot underestimate the importance of sleep and rest. You know how you function the next day when you have not slept well, you haven't gotten the rest that you need. Maybe you need to sleep at a different time in order to be able to accommodate your job. But we know we have many patients who have, you know, not necessarily regular daytime jobs. So our world is changing, and everyone is working different times, working from home, coming partly from home, partly not from home. So we're all trying to adjust with everything in our world. And I think we have to just try to do our best.
I would add to that, just as far as like the actual timeline of treatment goes, is we often have morning appointments and needing to get same day results, things like that. If your, you know, normal sleep schedule is sleeping from 4 or 5 a.m. when you get done with work at 3 and sleeping till noon the next day, you know, that could definitely start impacting your sleep if you have to get up at 9 or 10 a.m. to come into the office. But we always just tell patients too that it's not a requirement. You can't, you know, there's nothing that you would say, hey, I'm working till midnight and so I cannot start treatment now, or I'm afraid I'm going to lose my job because I work late, but I'm also doing treatment. You can absolutely, like Dr. Euler said, they can both go together. Sleep is really important. We know that for a fact. But it's not going to say it's one or the other for treatment. But just do know that there's, you know, different procedures and things like that are going to be happening during the day, which we have lots of night shift people, as Dr. Euler mentioned, and they have certain days off. And so they work out their schedule, or they let their employer know that, hey, I'm going to need certain times off, you know, during this 2-week period or 4-week period. So it's definitely manageable. And I wouldn't say that just because you work late means you absolutely, you know, either have to change your job schedule or do treatment. It shouldn't be, it's not an either or.
Okay. What are suggestions for men with low sperm counts who have had tests that show normal hormonal levels but decreased testicular size? Is there anything that can be done naturally?
Well, decreased testicular size is usually accompanied by elevated gonadotropin. So you know, if the hormone levels are normal, I guess that would be definitely an indication to refer to a male infertility specialist. So I assume this person has already gone to one to get and to know enough about the exam to know the testicular size is smaller and to know that the hormone levels are normal. So I'd have to know a little bit more. This is definitely within the expertise of our colleagues, our male infertility specialists. Perhaps I've seen our male infertility specialists do recommend vitamins in terms of coenzyme Q10 that could be helpful, men's formula for vitamins that contain antioxidants. So I think those are naturally occurring substances. Peter, I know you work with men also. Is this something
Yes.
that you make a few suggestions?
Sure. Yes, I see this a lot. I know I focused a lot on my presentation about the woman, but we do see a lot of male factor. And when patients come in and I see their semen analysis, you know, I tell them, you know, acupuncture is great for count, it's great for motility, morphology, no, but we still do a lot for it. And so we have Chinese herbal formulas that do help with all that. I do recommend, you know, different vitamin supplements to help as well. But especially when it comes to men, a couple things. One is a belly on a man is a bad thing. You want a guy to be as lean as possible because that's telling me possible higher estrogens in the body. And we also look at the diets. And I want my men weightlifting, especially a lot of legs, because most of the testosterone receptors are in the legs. And then, you know, other things you might want to look at is not just total testosterone, but what is free testosterone? What is the sex hormone binding globulin in relation to all that? That's the hormone that can bind up all the testosterone in the body. And sometimes he may have great testosterone levels, but the sex hormone binding globulin could be high. So we have to unbind it a little bit. And there's actually some simple fixes for that as well with basic vitamins. Acupuncture is effective for count and motility. We do it all the time. Now, if a man comes in who's azoospermic, who has no sperm, really we can't help with that. And again, like Dr. Euler said, I always refer out to, you know, to FCI, you know, for a deeper consult, because there can be an obstruction there or something in the vas deferens that, you know, I would have no idea.
Can you help explain unexplained for infertility, like elaborate? If a couple starts trying at 35 and then turns 36, during trying, would it be 6 months or 1 year? And what is the likelihood of getting pregnant naturally when everything else looks great, but it is considered unexplained infertility?
Okay, so I think there are 3 questions there. So
Yeah.
I'm going to try to remember them. Number 1, unexplained infertility is when we have tested the main battery of tests. So ovulation, female ovarian reserve, the male in terms of the semen analysis, and then the anatomy, the uterus and the fallopian tube. So if all of those tests are normal, then essentially that couple has unexplained infertility, which is about 10% of the cases, as I mentioned in my one slide. Now, it used to be a long time ago that we would have to laparoscope the patient on top of it to make sure they don't have endometriosis, but laparoscopy is a deeper study, but it is major surgery and it requires it to be done in the hospital. So we're not really recommending that unless there's something unusual. So it is about 10% of patients to have unexplained infertility after we do all the testing. So the second question, if you're 35 and going to be 36, what would be the definition of infertility? I would say trying 6 months or more would meet that definition. And then the next question is, what is the pregnancy rate? If a patient has been trying to get pregnant, has unexplained infertility, and I'm going to assume the age of 36. So if a patient has tried for over a year to get pregnant, and their chance of getting pregnant is roughly going to be on the order of 5% per month at age probably 35 to 36. And then with IUI, that would be closer to about a 10% chance of pregnancy. And with IVF, it would be closer to 50 to 60%, depending upon the causes of fertility.
Can I interject something just real quick?
Yeah.
Just real quick. So, you know, this is a common thing that I see in my practice. The patient will come in and they're like, well, it's unexplained. And many times there may be an explanation like age, you know, or PCOS or other issues. And I guess the point I want to make is more addressing the patient themselves, because it's a very stressful diagnosis that I found for a patient because they want some kind of an explanation. And, you know, this is something that we try and work with. And this is where too, you know, if it is stressing you out because you don't have endometriosis or, you know, decreased ovarian reserve, and they've done the whole battery of tests like Dr. Euler has mentioned, you know, I really encourage you to also seek out some of the help at FCI, you know, that Dr. Tiffany Edwards was talking about as well, you know, because for some patients, it's very damaging. It's very stressful because there isn't an explanation as to why they're not conceiving.
Yeah. For the embryologists, does IVF include only putting the sperm into the egg directly, or do we do it where the sperm and the egg are in a dish and meet on their own, or with a little bit of coaxing?
So we do both procedures. Like I said, ICSI is where we would inject 1 sperm per egg. But if a patient elects, we could also do conventional insemination, in which we put lots of sperm, millions of sperm around the eggs, and then the sperm would naturally penetrate and fertilize the egg on its own. So we can certainly do both types of treatment, whichever the patient elects. Most of the time we do ICSI, because we have a little bit more control. And if the problem happens to lie in the sperm binding in the egg, we wouldn't want to have to find that out after doing months of treatment. So sometimes we just nip that in the bud and go straight to ICSI, so we know that that's not going to be a factor.
Okay. And we've got 4 minutes left, so I'll try to answer as many questions as we can. I've heard that doing testing on embryos can harm or make them less likely to make it. Is that true?
No, our pregnancy rates from biopsied embryos are pretty much the same as doing a fresh embryo transfer. The amount of cells that we're taking off of the embryo is very small, and they're the outer cells of the embryo, so they don't really damage it. There's only about 5 cells, and a blastocyst has like 250 cells, so 5 out of 250 is not too many, and we see really good results with that.
And we're very strict with the embryos that we do biopsy. We won't biopsy a poor quality embryo that we feel won't survive the biopsy, freezing, and thawing process. So we will only do that procedure on embryos that are very high quality.
I would also add our embryologists just that they can, you know, from our experience at FCI, we're so, you know, we do this so much and we have such amazing embryologists that damage to the embryo doesn't happen. That doesn't say that at a different clinic, not following, you know, the same training and procedures that couldn't happen. Because I do know if, you know, we have patients that will say, well, I have, you know, my friend, or I heard someone that the embryos got damaged. We can't speak to what, you know, other clinics do, but from our embryologists who are very, very experienced and do this literally daily because of the amount of, you know, patients that we have and just how many procedures we do, we can say that those are our pregnancy rates, those are our success rates, and that we don't have damage happening to embryos. But we can't say that necessarily if you then find a, you know, a different clinic. Anytime you do any procedure, you could damage something if you do it wrong.
Yeah, that's very true, Allison. In other labs that are smaller, the embryologist may be doing biopsies once a month, you know, for 2 days out of the month. We are doing it every day, all day, 365 days of the year. So this is, you know, it's like riding a bike to us. We're very comfortable with it. And we honestly enjoy the procedure. It's fun to us.
Good. Okay, and then we'll do one last one for Judy. Can a patient elect to bypass the insurance requirements if they're paying privately or directly out of pocket?
She's muted.
Yes, they can. If they'll sign an insurance waiver for us, stating that they will not be submitting a claim directly to their insurance, and then they can go ahead and pay FCI directly and bypass the requirements of the insurance company.
Right, and I see you answered that in the chat after I said that. And then just quickly, is there a way to determine the sex with in vitro?
Oh,
Everyone's
yes,
getting
we,
it.
if we do that biopsy that we were talking about, and the test will tell us that the embryo is chromosomally normal and also whether the embryo is male or female. So we will know prior to implanting the embryo if it's male or female. And how often are there multiple births with in vitro? If we are transferring more than one embryo, then there's obviously a chance of having more than one pregnancy. So we try and minimize transferring more than one embryo unless the patient has had multiple failed cycles or if they're older in age. But how often? Not, not that often, I would say. Like, what is our pregnancy or twin rate?
I think it depends upon the age of the patient. The younger they are, the more likely, but I generally quote a 1.8% chance that one embryo would split to two, that putting two in, the twin rate is roughly 30 to 40%, depending upon the age of the patient, with a approximate 2% chance that it would split to three. So the twin rate does significantly increase with the transfer of two embryos.
Okay, we had a quick request to answer a question about polyps. So there was recently found a polyp on my uterus on one ultrasound that was not there before. I heard those are usually not something to worry about, but could interrupt with an IVF transfer. So I guess, could you elaborate a little bit?
So I would say that the polyp needs to be diagnosed on more than an ultrasound. I would recommend a 3-dimensional saline ultrasound to diagnose that polyp. And depending upon the size of the polyp, we do want the uterine cavity to be completely clear when we transfer an embryo in. So it depends on the size, if it's bothering the patient, but I would say in general, we would like the uterine cavity to be completely normal, no polyps, fibroids, any kind of scar tissue before, because we want to optimize that embryo transfer. So it may likely need to be removed via hysteroscopy.
And I know I saw a question just kind of flew by, but about how long after like a polyp removal or a hysteroscopy to go into IVF. And there is not, this is not a majorly invasive surgery, not like a laparoscopy where we literally go through the cervix. And so it can be like, right, we can still be getting you prepped for IVF and getting ready for that cycle with your next month. There is not like a downtime or we have to wait for it. It's something we can absolutely get you into FCI with our physicians in office, in our River North office that we have the IVF Center, River North and Highland Park. But whichever your physician works out of, we get you in there. You can do the hysteroscopy while you're prepping. If it's, your month with different medications or birth control, prepping for your IVF, and go straight into it. There's not a big lull or a downtime.
Agree.
Okay, everyone. Thank you so much.
Thank you so much for your time.
Thank
Really
you so much
enjoyed it.
to everyone who stayed on for the Q&A. We appreciate it. We will be scheduling another Fertility 101 very soon, and we'll let you know when that goes out. Okay. Bye.
Thank you.
Bye.
Bye, thank you.